We're going to start it up here, guys. Good afternoon, everyone. Thank you so much for joining Jeff Foundation's Community Workshop Series. We're going to just wait here a few seconds and let some more of our attendees get on before we begin. All right, we've got some more people joining us. Again, thank you all so much for joining Jeff Foundation's Community Webinar Series today. My name is Danielle Edwards. For those of you who don't know me, I am the Director of Community Engagement at Jeff Foundation and have been part of this organization for almost 5 years now. This year, our webinar series will be to help ensure our Duchenne community that is better prepared on certain educational topics, such as the one today. While I wish we could be doing this in person at our traditional family workshops, I'm so glad to be able to provide these virtual webinars for you. Today, I'm so excited to have two guest speakers with us. First speaking will be Dr. Jonathan Cordova, who is a pediatric gastroenterologist at the North Shore University Health System and is uncle to DMD warrior Levi Haynes, who will be speaking on GI health maintenance and feeding tubes. And our second speaker will be Rosalie Callahan, who is a mom to DMD warrior Christopher from New York, who will be speaking on their own personal experiences with feeding tubes, such as warning signs, swallow study, and much more. Please make sure to drop any questions you may have for our speakers in the chat section box below so they can answer any questions you may have after the presentation. With that being said, I hope everyone enjoys the webinar today, and I'll pass it over to you, John, to begin. Thanks, everyone.
All right, thanks so much. Danielle, can you hear me okay?
Yep.
All right, perfect.
Yeah, looks good.
There we go. Let me just minimize a couple things here. All right, perfect. So thank you again for the introduction, Danielle. It's always an honor and a privilege to be able to speak at some of these JET Foundation meetings and webinars. And yes, I appreciate, obviously doing them in person, and we'll get back there soon, but always happy to help and offer some expertise when needed. So always an honor and a privilege. Again, my name is Jonathan Cordova. I'm a pediatric gastroenterologist in the northern suburbs of Chicago at a hospital system called North Shore University Health System. And I was tasked today to speak a little bit about GI health maintenance with our boys with regard to feeding tubes. So NG feeding tubes, G-tube feeding tubes, what this means, how do we get there, and in essence, what's the process? So the outline of the talk will kind of be broken down in 4 sections. So first, we'll talk about some feeding intolerance issues with regard to our boys with Duchenne. We'll move then to speak a little bit about what nutritional intervention is. And as a gastroenterologist, this is kind of the mainstay of what my practice is feeding as therapy. Then we'll talk a little bit about feeding tubes, the different names of feeding tubes, what they look like, and how they're placed. And then we'll end the talk with a little bit of guidance regarding feeding plans. So just a little bit of anatomy to begin with. This is a schematic of what the upper GI tract or the upper gastrointestinal tract looks like. It consists of your mouth, your esophagus, or your food pipe. the stomach, and then the first third of the upper part of the small intestine, which goes by the name of the duodenum. Remember that the mouth and the esophagus are very critical structures that are needed to help swallowing, and to recall that the upper third of the esophagus, of the food pipe, is actually striated skeletal muscle, and this can be affected in boys with Duchenne. And the issues that we tend to see in our boys with regard to upper GI symptoms tend to be reflux or GERD, as well as this concept of dysphagia. So what is dysphagia? Dysphagia is, in essence, difficulty swallowing, and it's important to help differentiate the different material that's being problematic, meaning dysphagia for solid foods can mean something different than dysphagia for liquids and solids. So we want to pay attention to those differentiating factors. With regard to swallowing, there's really 3 phases of swallowing. The first consists of the oral phase. This is where you chew food and, in essence, turn the food into a food bolus. Signs and symptoms that we could be having issues with the oral phase can be seen with drooling, if our children are unable to handle their secretions or their saliva, if there's excessive chewing, or even spitting food out. It can be a sign that maybe there's an issue with the oral phase. The second phase of swallowing is the pharyngeal phase. This is where you move food bolus back into the posterior oropharynx, or the back of the throat. There's a complex mechanism that happens where your epiglottis closes to cover the airway, and this allows your esophagus to open up. So a tight little sphincter called the upper esophageal sphincter opens up and allows food to move from the back of the throat down into the esophagus. So this is the pharyngeal phase. And problems in this area tend to show up with gagging. So when kids start to swallow and physically move that food from their mouth down into their esophagus, gagging can be a sign that there's an issue here in this phase. And then the last phase of swallowing is the esophageal phase. This is mostly involuntary. This is under the smooth muscle control. And this is the involuntary passage of food from the esophagus into the stomach. And when I see kids with esophageal dysphagia, I tend to see kids who complain that food gets stuck after they swallow. So they'll chew, they'll swallow, and then they'll feel the food getting stuck kind of mid-chest. They may show up with something called a food impaction, where food truly is stuck and needs to be removed endoscopically. Or these kids oftentimes can vomit undigested food. So if the food sits in the esophagus for too long and comes out, it's going to look like the same material that was initially swallowed. But do remember that, like we talked about, skeletal muscle is involved in all phases of swallowing, from the oral, pharyngeal, and the esophageal phase. So this is a study that I found from about 5 or 6 years ago that wanted to help quantify some guidelines or some recommendations with regard to dysphagia in our boys with Duchenne. It previously hadn't been done. So this schematic is a nice little diagram that indicates what we're looking for when we're talking about dysphagia. So the biggest risk of dysphagia is aspiration. So this is where food material, instead of going into the esophagus and food pipe into the stomach down the GI tract, can unfortunately go into the lungs, down the trachea, and lead to complications like pneumonia. So this bottom schematic, I don't know if you can see my mouse here, but this is a cross-sectional view or a cutoff view of the face. This big gray thing here is meant to be, or to depict the tongue. There's 2 pipes here. The front pipe is your trachea, which leads into your lungs, and the back pipe in white is meant to be depicted as the esophagus, and we want food to go this direction. So the biggest complication when you swallow in boys with dysphagia is whether or not we're aspirating. So is food material making it, unfortunately, past the vocal cords into the lungs, which can lead to pneumonia. Prior to aspiration, we tend to see kids who have what we call penetration. And this is where food material will go both directions, down into the esophagus appropriately. And some may get hung up right at the vocal cords, or even make it a little bit below the vocal cords. But boys with enough lung capacity, enough residual capacity, and enough cough support can actually be able to cough out this material and get it back down into the proper direction. But penetration can be a sign that, hey, maybe aspiration's a potential complication down the line, something we need to pay close attention to. And then there's this concept of residue, and this happens in anybody. Is once you swallow, some food will get stuck in the back material, but again, with enough lung capacity, enough cough support, we're able to get this out, either expelled or swallowed appropriately. A little bit of a busy slide, but this is in this paper kind of an algorithm of what we should start thinking about at our visits with our healthcare providers with regard to dysphagia. So in essence, we want to make sure our boys are getting followed up every 6 months. We want to ask the questions about dysphagia, simple screening questions, which I'll talk about on the next couple slides. If there are signs of dysphagia, the question about reflux will always come up, and whether or not our kids could be having signs of acid reflux or regurgitation of stomach acid material back into the esophagus, which could be leading to some of these symptoms of dysphagia. So there's always questions about reflux that we want to make sure it's under control, treated, whether with lifestyle changes, diet changes, or possibly even medications. If reflux is taken out of the picture, the big question then is, what is the oxygen saturation, or could there be a chance that we are aspirating? Kids who aspirate and develop pneumonias or silent pneumonias, or what we call aspiration pneumonias, will oftentimes have an oxygen saturation a little bit less than what we expect. If the oxygen saturation is low, then there's a concern of, yes, we're aspirating, then we're going to jump down completely to this bottom, which are that, hey, listen, maybe it's not safe to eat orally, and maybe we should start thinking about feeding tubes. But this is a nice algorithm. Again, a little bit of a busy slide. I'm happy to share this with you to kind of walk through after the talk. But this is a nice thing that should be brought up every 6 months at your visits. Again, another busy slide, but this gets to the question about how can we surveil our kids with dysphagia who have Duchenne with regard to surveys and questionnaires. So this was a study that came out about 10 years ago that looked at a previous swallowing survey to depict, or I'm sorry, to pick up reflux, I'm sorry, to pick up dysphagia. So on the left side are all the questions that were asked in the survey. Things from difficulty swallowing thin liquids, difficulty swallowing thick liquids, do they choke or cough or gag when they swallow, then with regard to solids, and then a little bit more to differentiate how much it's affecting their day-to-day life. And the first group of kiddos that they surveyed, there were 9 in total. Group 1 were boys with Duchenne who actually in their medical charts screened positive for symptoms and signs of dysphagia. Group 2 involved 6 boys who had Duchenne, who actually in their medical review and medical chart history review did not show symptoms or signs of dysphagia. And then group 3, 12 boys that were healthy controlled, sometimes sibling brothers of boys with Duchenne. And the outcome of their study, I'll walk you through over here on this left side. This first sign is, this is group 1. These are the boys with dysphagia, with Duchenne who had symptoms of dysphagia. When you compare those to group 2, which were boys with Duchenne who did not have dysphagia, they screened much higher on the survey with regard to positive answers for symptoms of dysphagia. Interestingly, the boys with Duchenne who did not previously show symptoms or signs in their medical chart compared to normal control boys actually also screened positive. And it was statistically significant. So this just tells us that this survey should be done, again, every 6 months or every year, even in our boys who aren't outwardly showing signs or symptoms, because they may actually pick up some discriminative factors with regard to boys and maybe some trouble that they're having swallowing. And this is, again, just kind of for health maintenance to make sure we're catching these kids early so that we can intervene at an earlier stage. So how about enteral nutrition? So, you know, as a pediatric gastroenterologist, again, this is kind of the mainstay of what I do with regard to making sure that the nutrients, the nutrition that our children receive for any issue is helping to sustain healthy, active growth. So what is enteral nutrition? I mean, this is what you and I do every day. This is what our boys do every day. This is, you know, in essence, eating and getting calories into our body so that we can grow. Enteral nutrition, when we speak of this specifically, tends to mean formula and or blenderized food that can go into the GI system. Enteral nutrition is really the mainstay to keep the integrity of the GI tract intact. There is something called parenteral nutrition, which is IV nutrition that does not use the gut, which is a little outside of the scope of this talk. But in essence, if the gut works, we like to use it. So this talk will focus mostly on enteral nutrition. And then who really needs enteral nutrition? Really, it's those kiddos who can't, or who eat less than about 80% of what's needed orally. If it's taking too long for these kids to eat, if it's 2-3 hours of trying to get meals in, which is unsustainable, we'll think about using enteral nutrition. Or in our boys, like we talked about, issues with dysphagia and concern for aspiration, where it may not be safe to eat by mouth. this is kind of how we progress through the interventions of, do you need a tube? What does the tube mean? And how are we going to get you from one stage to the next? So obviously we talk about attempting oral feeding first if it's safe. Again, if the gut works, we want to use the gut. If they can't tolerate feeds orally, then we start thinking about these things called tubes. And the first tube we tend to think about is something called an NG tube, which we'll talk about a little bit later. And then if the NG tube is not working, or we're having side effects, bloating, vomiting, intolerance to feeding, we can actually drop a more distal tube or a longer tube out of the stomach into the intestine called a transpyloric tube to help sustain growth and get calories that way. A little bit about appetite. This is our appetite's regulated in a few areas in our brain, both in our brainstem and our hypothalamus. These are kind of the central regulators of are we hungry, are we not, when are we full. There are some other hormones, something called leptin and ghrelin, which kind of regulate our appetite. Ghrelin promoting appetite, leptin suppressing appetite. And these are all kind of interrelated between what goes through our gut, medications that we're taking, and our overall mobility. Things that can decrease your appetite and may lead us to, again, desire to need to use enteral nutrition can be disease in of itself. Certain medications can affect our appetite. Obviously, many of our boys are on steroids, and as we know, they can really increase our appetite. But as those medications stop or slow down, we might notice that the appetite decreases. We might notice some weight loss, and we really need to get on top of adequate nutrition. If there's electrolyte imbalances, some of our boys in general can be pretty picky, and we want to make sure we're getting adequate nutrition with adequate what we call macro and micronutrients. And if there's any deficiency in any of these can also decrease our appetite. If there's decreased gastrointestinal motility, so I gave a talk about 6 months ago to this group with regard to constipation. We know that boys with Duchenne may have a higher incidence of constipation and poor motility, and if you're full of stool without going often, that can also affect your appetite. So, you know, many different causes, but things we need to be aware of when we're starting to think about enteral nutrition as therapy. Most of the enteral nutrition we talk about will come in the form of formula, but these are also important factors that we need to take into account, is how much formula do we need to sustain a healthy, active feeding plan and with active growth parameters. With regard to cardiac issues, some of our boys do go on to develop some cardiac issues and signs of congestive heart failure. So sometimes fluids, overall fluids for the day, need to be adjusted. If our kidneys are taking a hit for any of many reasons, medications can be a big cause. We also have to be cautious about the type of fluid we're using. We need to monitor electrolytes frequently and make sure that the amount of protein that our boys are getting is adequate. So a lot to take into account when we're picking different types of formulas or nutrition. All right, so what about feeding tubes themselves? So a little introduction to feeding tubes. So there's really over about 300 different medical conditions that can really require the need for what we call tube feeding. But it's not limited to, you know, it includes, but it's not limited to genetic issues, chromosomal abnormalities, respiratory or cardiovascular compromise. In my line of work, gastrointestinal issues, but then obviously neuromuscular conditions like Duchenne can necessitate the need for a feeding tube. It's really important to remember that, you know, that no two children's tube feeding experience will ever be the same. So, you know, I really look forward to hearing our next speaker with kind of her journey through what it's been like regarding her child with a feeding tube. But this really does need to be individualized. So every decision made on what tube and why and when and how and what type of feeding really needs to be patient specific. So these are a variety of the different tubes that we use. They're all abbreviated. So when you start hearing them by abbreviation, at least hopefully after this talk, we'll be able to kind of differentiate where the tubes end up and what they actually mean. So the first tube, the most common tube that we use, is called a nasogastric tube, or an NG tube. That's depicted in this picture at the top here. So you see a tube coming through the nose and ending up in the stomach. There's a longer tube called a nasojejunal tube, or an NJ tube. This tip goes through the nose, leaves the stomach, and ends up in the small intestine. If these tubes are really thought to be temporary, several months, if the thought is that we need a little bit more of a permanent tube, then we'll start thinking about other tubes like a G tube, which is depicted down here. This is a Mickey button, which we'll talk about shortly. This is a G tube. Or there's a GJ tube, so same concept. We can make the tube internally leave the stomach and go a little deeper into the intestine, but on the outside can look a lot like this. And then there are specific tubes called J tubes, which don't enter the stomach at all and enter into the intestine specifically. So again, something we'll talk about here in a couple slides. So the tubes, again, are named by where they go. So the first tube, called nasogastric, NG tube, and D tube for nasoduodenal, which is the first part of the small intestine, or nasojejunal, which is the middle part of the small intestine, all start in the nose, come down the esophagus, either end in the stomach as an NG tube, or leave the stomach and go into the small intestine called an NJ tube. Again, these are temporary, meant to be in place for a couple months, and if needed longer, we start to think about our next set of tubes, which are called gastrostomy tubes. These go by different names like PEG tube, balloon tube, button G tube, and these go directly from the skin on the outside, like I showed in the previous picture, directly into the stomach. And then lastly, the tube that we talked about is called a Jejunostomy tube, or a PEG or PEJ tube, and this is often done by our surgical colleagues, which we'll talk about again, but this goes directly into the intestine and bypasses the stomach. Again, just an NJ tube. NJ are these nasal tubes, in essence, through the nose and then into the stomach or into the intestine. What about a G tube? Again, this is a tube that gets placed either surgically or endoscopically. This goes right into the skin from the outside directly into the stomach through an opening that we create called a stoma. So how are they placed? So there's a surgical gastrostomy tube. This is done by often a pediatric surgeon, and this is under general anesthesia, and this is an actual surgery where the surgeon will use cameras to insufflate the abdomen, find the stomach, and then insert a G tube directly under direct visualization. This is done commonly, but the more common thing that we see in our practice is what we call a PEG tube, or a percutaneous endoscopic G tube. This can also be done by a surgeon or by colleagues like myself or gastroenterologists, and this is done via an endoscopy or a fiber optic scope, and this is considered minimally invasive and in essence gets us to the same place. All right, Danielle, I'm going to try and show this video very quickly for 2 minutes about these tubes, and hopefully if it doesn't, let's just try really quickly. Here we go.
If your child will need a tube longer than 2 to 3 months, a gastrostomy tube, or G tube, may be a better option. A G tube is a tube that goes through the skin of the belly and into the stomach. Formula is then put through the tube to feed directly into the stomach. There are several ways a G tube can be placed. Often, we choose a percutaneous endoscopic gastrostomy tube, or PEG tube. This is done with the use of a small, flexible camera called an endoscope and minimizes cutting of the skin. It is considered a minimally invasive procedure. To place this tube, your child will have to be under anesthesia. That means they will be completely asleep during surgery. The doctor will be able to use the camera to look inside the stomach and find a safe area to place the tube away from nearby organs, such as the liver and the colon. Once the correct place is located, the doctor will make a very small cut on the skin. This allows for a thin metal thread to be used to pull the G tube through the mouth and out of the stomach. The end of the G tube has a soft bumper on it, which will keep the tube from being pulled out. A stabilizer on the skin side of the tube will help keep it in place. If the doctors can't find a safe place for the tube with the endoscopy camera, they may decide to place a G tube a different way with the use of laparoscopic cameras or through open surgery. The skin and stomach will heal together, creating a connection called a tract. This takes about 3 months. Once it is healed, most children can have the tube changed to a short tube or a button, which sits flat against the skin. If your child does not tolerate feedings into the stomach, This tract can be used to place a longer tube called a gastrojejunal or GJ tube. This does not require another surgery, but will be done with x-rays. Feeds given by a GJ tube.
All right, I'm going to stop there. Hopefully that worked okay and you guys could hear everything. In essence, that's the schematic. That's what we do endoscopically to place these G tubes. It tends to be a 24-hour admission to the hospital afterwards, and we start using the tube about 6 hours afterwards. Look for signs of infection within 24 hours, fevers. We like to start initiation of formula feeds in the hospital, make sure that everybody's comfortable using the tube, and then usually within 24 hours, you can go home. So what are tubes and what do they actually look like? So there are long tubes, as the video talked about, and also low profile shorter tubes. So the more common tube that we place initially is a long G tube. So this, in essence, are what the tubes look like here on this left side, and this image depicts what it looks like on the outside, which is, it's all one piece. So there's one piece here, there's a balloon on the inside that keeps it attached inside internally to the stomach to prevent it from falling out. There's a little bumper that sits at the skin level. And then everything that we need to use with the tube regarding on what kind of tube sits on the outside. So it's a little bit longer, looks a little bit cumbersome at the onset, but this is really what we like for about 2 to 3 months. While the surgical opening from that hole we created, it starts to mature and heal. And then after a couple months, we're able to take this tube out, deflate the balloon, and insert a smaller tube like this called a low profile tube that in essence has all the same compositions of this tube, but will need what we call an extension tubing to pop open this cap, and then we plug in the tubing at the top to allow our formula to go through. But this is obviously a lot smaller, a lot easier to manage and maintain. And the names that you may hear of when people talk about G tubes are something called a Mickey button or an AMT mini or even a BARD or Boston Scientific. So that's what they're talking about, is these small little tubes. Again, on the outside, this is what they look like, just another schematic. On the left side, the long one-piece tubes that we tend to keep in place for a couple months, and then eventually a small tube like this. So this again looks like what the tube is here. There's a balloon on the inside that's insufflated, usually with sterile water to keep it in place. This tube, in essence, is held in place from the skin on the outside, muscle layer, and then eventually stomach down here. And then there's a little opening that allows us to add liquid to the balloon if the balloon is becoming deflated, and then allow us to use the top to allow formula to go directly into the stomach. And again, another schematic of what it looks like in cartoon fashion of what that balloon looks like inside the stomach. So that was all about G tube. So what about this thing called a GJ tube? So it's the same concept. A GJ tube is a tube that is placed via the opening or that stoma that we created. And we pass this area called the pylorus, which is the end of the stomach, and we push the tube deeper into the small intestine, or the second part of the small intestine called the jejunum. So that's where GJ tube comes from. There are a couple extra ports on the outside which allow one tube to kind of enter into the stomach. We usually use that to give medications. And then there's a J port, which allows us to hook up to feed so that we can give kids their nutrition directly into their small intestine. How are these placed? These are oftentimes placed by our interventional radiology colleagues. So what happens is most kids will get a G tube from the onset several months, and if we feel that it's not working from a side effect standpoint, bloating, vomiting, intolerance of stomach feeds, then our interventional radiologist will take out the tube, they'll place a wire directly from the outside, and with the use of x-rays will help guide that wire down into the intestine. When the wire is deep enough in the intestine, then they'll insert one of these GJ tubes directly over the wire so that they can guide it down into the intestine, and then we'll inflate the balloon and then go home. So usually that's a same-day procedure. And again, what GJ tubes look like, very similar concept, just one extra little port on the outside of the tube, but they do make low profile ones as well. And then the last type of tube is called a Jejunostomy tube directly. So you can see we took out the G portion, so that has nothing to do with the stomach. And this is done by our pediatric surgeon. So this is placed directly into the small intestine. There are some issues with some of these tubes, and some of these tubes will become dislodged. So if we have, let me go back to this slide. If we have a GJ tube in place and something happens for unforeseen reasons and the end of this tube ends up back in the stomach, then obviously we're not getting the benefit of what we call a GJ tube. We're actually feeding the stomach, and this tube may then have to be replaced by the interventional radiologist and replaced. So this is a tube that if it comes out, GJ tube, cannot be placed back by the parent or the caregiver. It has to be done with interventional radiologist. So for some reasons, if the tubes keep coming out, then what we'll say is they may need a direct jejunostomy tube or a J tube. And again, our surgeons will place this. All right, so that was all about tubes. And feeding plans, again, like we talked about, really need to be individualized, kiddo to kiddo. Why would you pick a G tube? Why would you pick a J tube? Again, most people will start initially, I would say the vast majority, with a G tube. And again, this allows us to feed directly into the stomach. So this mimics, normal physiology of feeding into the stomach. Your stomach has a brake mechanism to allow slowly food to be processed, digested, and to slowly enter the small intestine, where your intestine can absorb your formula and turn it into energy for your body to use. If we're bypassing the stomach, which is what we call the reservoir, and we feed directly into the intestine itself does not have the residual capacity to hold onto large volume of formula. So whenever we're feeding into the small intestine, it has to be under what we call continuous feeds. So this is low volume over a long period of time. This may require that our children are hooked up to a feeding pump for anywhere from 12 to 14, even 18 hours a day to make sure that they're hitting all their caloric goals to sustain growth. But the downside to J tubes, anything that ends in a J, is that you cannot give a large volume feed. It has to be done continuously over a long period of time. Again, this is kind of that concept of this thing called bolus feeds. Bolus mean large volume feeds over a short period of time, but often done multiple times a day, versus continuous feeds, which are slow infusions, but need to be given over a long period of time. How do we give feeds? What does it mean to actually hook up a feed? So this kiddo on the left side here in the purple has an NG tube, and he's actually holding a syringe. He popped off the plunger, and we'll put some formula directly in there. And with the help of gravity will slowly empty that syringe out into his stomach. It can take as little as 10 minutes, oftentimes 15 or 20 minutes to finish a feed. And that's one way to give it. On the bottom side is what we call a gravity bag. So same concept, but you pour the formula or nutrition directly into the bag, and it can run directly through gravity into the stomach, whether it's a G tube or a naso tube. And then the top picture indicates what we call a syringe push. So same concept, you can put formula feeds directly into the syringe itself, and with the plunger you can syringe it and push it directly into the stomach. And the help of this is that it's quick. You can do this over several minutes. What about longer feeds? So these are things that you might see if we get a feeding tube. These are called pumps. There are a couple different brands. The most common ones I see out there are the Kangaroo or the Infinity. These are pumps that in essence you hook up the tubing to, and you can set it, and it will automatically push in the amount of formula that you input over the amount of time that you want. So if you want a feed to go over 30 minutes, you can input it, and over 30 minutes it will empty out the formula directly into the GI system. These come in small little contraptions that are depicted here, and they can fit easily into these little backpacks. So I have a lot of patients who have jejunal feeds, NJ feeds or GJ feeds, who wear these throughout the day to make sure that they're getting their proper nutrition. Let me just quickly talk about medications. So the caliber of the tubes are a little bit bigger, meaning the G portion of these tubes diameter-wise are a little bit bigger. So we recommend giving medications through the G portion. If we give medications through the J portion, which the diameter is a little bit smaller, we run the risk of having a clogged tube. And one of the biggest downsides to these tubes are that they can become clogged pretty easily. So We prefer using any liquids that we're giving as, any medications that we're giving as liquid form, preferably. If not, if some medications can't, then we ideally have to crush capsules or pills, and then we recommend you definitely use the G portion. And flushing, meaning using sterile water, using water in general, before and after giving any type of medication to prevent the residues from that medication getting stuck to the tubing and, in essence, limiting the risk of becoming clogged. And then after formula feeds as well, we always recommend giving a good flush of 1 to 2 ounces of sterile water, again, to help the residue from the formula leave the tube. Lastly, just some basic care of tubes. These are things that we just recommend on a daily basis, if not weekly basis, for some of our tubes. So you want to wash the site on the outside with soap and water. Make sure that the skin is dry. Try to avoid hydrogen peroxide, can cause a little bit of irritation to that area, and try not to apply any occlusive dressings. We want to look at the skin for signs of infection. We want to make sure that it's not leaking or skin breakdown. We have lots of different barrier creams and lotions that we can use if it does look like the skin is getting a little irritated on the outside. If the tubes leak, if we start noticing that formula is coming out, oftentimes what's happening is the balloon on the inside is becoming a little deflated. So sometimes we'll add a little bit more water to the balloon. And that's something that's often done with a phone call to the GI doc or the surgeon. And we always recommend and make sure that if you do have a feeding tube, that there's a replacement feeding tube at home. Like I said, some of these tubes and G tubes or G tubes will get pulled out accidentally, and being able to replace or have something to stick in the tract to keep it open is always helpful. We want to make sure that if you have a low profile tube, these tubes as kids grow do need to be upsized, so the diameter of the tube can increase in size, as can the length of the tube from the outside skin all the way into the stomach. Think about if we have a kiddo who gets a G tube at age 8, by the time he's 11, 12, 13 and is grown, will likely have a very tight fitting G tube. So we do want to make sure that they're changed out and measured appropriately at least once a year. The outside can cause a little bit of pressure irritation on the skin, that little hub that we showed you. So we do want to rotate that a couple times a day. And then a little bit about unclogging tubes and making sure that you're flushing after all feeds. And then lastly, this was a nice study, came out about 10 years ago also, that just wanted to look at how efficacious are G tubes specifically in our population with boys with Duchenne. So this was a study that came out, looked at 25 boys, young adults, 23-year-old median age, for several reasons, who had G tubes, and in general just wanted to see how they did afterwards. And this, small study, but it did suggest that, G tubes are very well tolerated, and it can really help improve the nutritional status individually with kiddos with Duchenne. And that is it for me. This is my my little warrior. This is Levi Haynes. This is my nephew who's got Duchenne. So always doing this for him. And with that, Danielle.
Yep. Thank you, John, for that presentation. That was fantastic. We'll take questions at the end, and right now we'll throw it over to Rosalie Callion to talk about her experiences.
Hello. First of all, I have to apologize. This is a very busy time in my house. My husband comes home, my younger son comes home, the dogs get excited. So I apologize for any background noises. So my son Christopher is presently 14 years old. Actually 3 years ago, almost to date, maybe a little bit longer. It started in February. He started having some difficulty with swallowing. He started coughing a little bit after he ate, like he had a tickle in his throat. He was having difficulty chewing. So at that point, we were seeing Dr. Long in Cincinnati, and we were just about due to go for our 6-month checkup in February. And, I mentioned it to her that what I was seeing, and they scheduled a swallow study for him. So we went in and I brought different types of food for him, and they included, they added to it like a contrast, and he had to eat it, different consistencies, and they x-rayed it as the food went down. What they noted was that he wasn't clearing his food. It was getting caught in the back of his throat, and then it was kind of trickling down. So they taught him how to dry swallow after he chewed something. So he would have to take a mouthful of chopped foods, and he would swallow, and then he would swallow again, and then he would rinse it down. You know, we thought that that was going to help the solution, that was going to be the solution. And we came back after his visit, and probably about 2 weeks after that, I got a phone call from the school saying that he had just eaten lunch and he is coughing, 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 and it's getting more frequent, more, and he wasn't able to catch his breath. So I picked him up from school, not knowing exactly what it was. I just brought him to the emergency room because we were due for a big snowstorm the following day. And I figured this way, at least my bases are covered if we need anything. And to my surprise, as much as we know, you know, having a child with Duchenne, it's always the unexpected. And as we were there and they started taking x-rays and you know, all the routine blood work and everything, and his oxygen levels were down, like Dr. Cordova had said, and they couldn't get them back up. And they wound up admitting him to find that he had aspiration pneumonia. And due to his decreased pulmonary function and decreased cardiac function at that time, the cardiologist and gastroenterologist and pulmonologist were all called. They worked with Cincinnati, and it was determined that they were going to put in a G tube for him. The first step of this, well, I'm sorry, let me back up. So they started treating him with antibiotics and IV antibiotics. They stopped him from having anything orally at all, whether it was liquid or food, for about 3 days. Once they got everything kind of calmed down, they went in, they put an NG tube just to look to see how everything was in there, the anatomy, and then they determined they were going to put a peg in. My suggestion to you, and being a Duchenne mom, I think we're kind of tough animals, you know, we kind of can endure anything and separate our emotions at the moment that our child is having something done. This was the one time that I almost beat the living daylights out of the doctor and started crying in front of my son while something was being done. They decided to do the NG tube, and they didn't spray, they didn't numb, they didn't twilight him, anything. And it was the most horrible experience. And our boys are tough and they could pretty much take anything, but I've never seen Christopher cry and beg me to have them stop. It was horrible. We got past that. So remember that if, God forbid, your children ever need it, that's what you want to make sure that they sedate or do something to alleviate some of that stress and discomfort for them. So they put in the NG tube, they did the x-rays, they put in the peg, quick procedure, everything went well. They taught us, you know, they showed us what it looked like. And like Dr. Cordova said, it was outside the belly at that point, it was longer. And their intent was in 3 months to replace it with the Mickey button, which they did. So now we have, you know, a Mickey button, which is quite easy to take care of, more than I ever thought it was. I was a little nervous and scared having to do these feedings and to be responsible for taking care of a Mickey button and replacing it every few months. So I just kind of gathered up some of his stuff that we have at home. Like Dr. Cordova had said, Christopher does not tolerate a bolus, so he has to get it infused over time. So we have a kangaroo pump, and this is the feeding bag with the line. Sorry, my hands are not working. And this is the extension tube, and this little part gets attached to the top of the Mickey button and locked in. And then this gets attached to this, to the cord of the kangaroo pump. For medications, you do have to crush it well. What I found was really good was we got one of these, and I can't remember for the life of me what it's called, and I crush his medicine every morning, all the pills, and I add it to water, and I add any liquid medication, and I feed it through. He does have the backpack, which if we're on the go, we just put it in there. His feeds take about an hour to get 240 milliliters in. He uses Kate Farms because he's got a lot of food allergies, and this was the only one that was good for him. Suggestions is if you go anywhere, if you need to visit the ER and there's a chance that they might hospitalize you, or you're going to the hospital or doctor's appointments, to always have your extension, your pump, bags, and feeding, because they do not, the emergency room, and I learned the hard way, emergency room in the hospitals do not have this stuff. At least they don't on Long Island. They don't have these, the pump, the syringes, any of that stuff on hand. As well as Dr. Cordova had said about keeping an extra Mickey button or G-tube available at home. Absolutely, because Christopher's went bad and dislodged, and we couldn't get another one in. And we went to the emergency room, and they did not have it available, so they had to place something in. They put like a tube in just temporarily until we can get to the gastro doctor the next day. So lesson learned, we carry everything, and we always have an extra Mickey button on hand. He tolerates it very well, and there's no limitations as to what he can do. He swims, he goes in the hot tub. He does everything that he possibly can. And it's irritation. That's right, sorry. Dr. Cordova was talking about irritation. And one of the things that we use are these little gauze pads to put them underneath if his irritation, especially during the summertime when he gets hot and sweats a lot, then that's when I see a little bit of the irritation more. So we make sure it's always clean and dry, and those pads help to eliminate irritation.
Thank you, Rosalie, for sharing that. Your raw and real experience. And then, Dr. Cordova, thank you again for your presentation as well. I think this was really helpful information. Right now, if there's any questions someone has, please feel free to drop in the chat. I know we've got a few from some parents over the weekend. We'll start with those first and then give you guys some time to kind of trickle in yours. Dr. Cordova, this one's for you. This is from a family. My son is on a G-tube for breakfast mainly, was in the hospital for 3 weeks in December, being on a vent for 2 of those weeks. Since then, the throat has slowed down in the squeezing of food down the esophagus, and the esophageal flap has gotten slower. Now we are no food by mouth, only by G-tube. Here's a few questions. 1, being in the vent for 2 weeks, could it have caused this issue? 2, will some type of swallow therapy help? And 3, will or could just time help or hinder?
All right, good questions. It's a little difficult. I think the question is kind of what led us to the hospital initially and what put us on the vent, right? So if the thought is that this is progressing disease, I think feeding therapy regardless is going to be helpful for any insult. If you kind of maybe look back at the past 6 to 12 months of his life and think that maybe the swallowing was progressively getting worse, then it might be a sign that the disease itself is progressing and that maybe, maybe it is, safer to not eat by mouth. If you really think that it was just an acute injury, whether he had, some sort of infection that led him in the hospital and then affected the lungs, as that gets better over time, I would presume that his swallowing could easily come back. Had he been eating only breakfast through the tube and everything else was oral, then I would think that yes, things can definitely be reversible. But if they think it's not safe for him to eat now at all, I think the feeding therapist, like your question alluded to, would probably be the best to give you the best guidance, right? So, I talked a little bit about aspiration, and it's also important to know what you're aspirating, right? So if thin liquids like water or juice, those tend to be easier to aspirate. Oftentimes during a swallow study, as Rosalie had mentioned, either done with the radiologist and a feeding therapist in collaboration, or sometimes our ear, nose, and throat doctors will do these tests. But if it looks like the consistency of the food just needs to be thickened a little bit, that's often what we'll do too, right? So we'll take a thin liquid and we'll add something to it to make it thicker to allow kids to be able to swallow a little bit better. So I would say work with your feeding therapist if you have one, or your speech therapist specifically, to see, kind of where we are. Let whatever insult happened that led him in the hospital, leave his system, and then, kind of start from there.
So thank you for answering that. We have another question, and I think maybe you both can answer this, but are the boys not able to swallow liquids at that point? Do they ever still drink fluids if their throat gets dry? Can they do a liquid diet by mouth?
Yeah, again, it depends on what's getting aspirated. So this is where a swallow study, oftentimes done once a year or every 6 months, can be really helpful. Our ear, nose, and throat doctors can do, a swallow study is a little bit of radiation. It's a barium mixed into a vehicle, so some sort of food, whether it's liquid, pudding, mashed potatoes, the consistency will become a little thicker. And as they swallow, we take x-rays, and then we can see that kind of that picture that I showed you initially is, are you penetrating? Is it kind of getting close to the trachea, or is it aspirating, going down, right into the lungs where it's aspiration? But ENT doctors can do something called a FEES, a fiber optic endoscopic something swallow study. But this is uncomfortable. This is a tube that gets placed in the nose when kids are awake, and they swallow, and they can visually watch as the material goes into the back of the throat. Is it going into the lungs or not? So this is an uncomfortable test. So that, Rosalie's point to how an NG tube placement can be pretty traumatic, this test can also be pretty traumatic for a kiddo. So the question in general is, are they able to drink? It's all dependent on their level of dysphagia. And if the speech therapists really think that, hey, listen, thin liquids are just, they're putting us at risk to get pneumonias, then the answer, unfortunately, is no, we can't drink thin liquids. But maybe the option is to thicken something a little bit to make it easier to go down.
Okay. And what about once on, once again on G-tube, will they ever eat real solid foods?
Good question. Again, same answer. In general, when I place G-tubes for other indications, we always tell parents that they're, in essence, not permanent, right? So they can be removed at any time. But in this instance, and unfortunately with the progressive skeletal muscle degenerative disease, if the thought is that the dysphagia is now affecting the GI system and putting us at risk to get pneumonias, it's likely that once that G-tube goes in, that it's likely not going to come out. Again, doesn't mean that they're never going to eat orally. The hope would be that they'd be able to have something. Sometimes even for kiddos who aspirate, we'll do something called orals for taste, where kiddos are at least chewing food, enjoying something. Remember, every kiddo, despite whether you have a G-tube or not, does produce saliva, and they're constantly swallowing their saliva. So some liquid is going down. So sometimes we'll have kids chew for taste and then, spit food out. It might seem unpleasant, but, it does give some gratification from an appetite standpoint. So the answer is, maybe.
Okay. Rosalie, do you have anything to add to those, or?
Christopher uses the Flexi mug to drink, and it is thicker liquids. So he can only drink from a straw. It helps him to manage it a little bit, little sips at a time. He can't drink from a cup because then he will aspirate again, or he starts with the tickle and the choking. As far as food goes, he does have little tastes of things. Food is such an important part of our lives, and it's a very social event for us, especially in our family. So when it was eliminated from him totally, it was, very traumatic, as it is for anybody. But the doctors had suggested, Dr. Wong had suggested, even if this at any point we can go back to food because of the Duchenne and the nature of the disease, that they would not suggest taking out the Mickey button. Just because, you know, inevitably, unfortunately, the odds are that he'd wind up back with a Mickey button and they wouldn't want to do another track. It's harder to do a second track.
Okay. All right. We have some other questions coming in now too. We have issues with intermittent bloating with our G tube. Maybe every third day will lead to a hard belly bloat that resolves itself overnight, but is very uncomfortable. At what point should moving to a J tube be considered?
Do they vent it? Are you venting the G tube?
We
By
don't
putting, because Christopher gets that as well, and all we do is I hook up the extension tube to the Mickey button and just leave it and just put a little bit of pressure on his belly, not a lot, and all of a sudden all this air and gas will come out of it and he'll feel better.
Okay, thank you for that, Rosalie. John, do you have anything to add, or?
You know, I agree. I mean, venting a G tube is really helpful. Remember, you know, we can expel gas by burping. Sometimes with the progression of this disease, you know, our boys can't burp. So venting a G tube is really important. So like Rosalie said, you can use an open syringe. They do make these products called Ferrell bags. Rosalie, I don't know if you've ever used those, but it's the same concept. And the bag, in essence, kind of draws air out of the stomach and can really help it get rid of gas. Sometimes using something called simethicone. Simethicone goes by brand names of Gas-X, and Mylicon, and that can really help burst up bubbles in the G tube. It comes as a liquid. You can put that right through the G tube after a feed, help break up some gas bubbles, and then vent it afterwards. My hope would be that if it's bloating that gets resolved, if you can vent it and it improves, you know, you probably don't need a J tube yet.
Okay, so if they wrote back and they are doing that prior to every feeding, so I guess now when would you consider it a J tube?
Depends on tolerance of feeding in general. Sometimes what we'll do even before we go to a J tube is we'll have kids use their G tube like a J tube, and we'll have them give continuous feeds to see how they tolerate it. So instead of giving a big, like Rosalie mentioned, you know, his feeds, Christopher's feeds are 240 mLs, probably a couple times a day. You know, we may say, let's give that 240 mLs over 2 or 3 hours and simulate a continuous feed and see how we tolerate. If things get a lot better, what I tend to do before I jump to a J tube, you can hear my resistance a little bit on J tubes, and you know, they're great tubes, but you know, they can become a little bit more problematic than G tubes. But sometimes I use a medication called erythromycin. Erythromycin is an antibiotic, a very old antibiotic, and not using it for antibiotic reasons, but can actually promote gastric emptying. So this medicine binds to the end of your stomach right before it leads into the intestine, and it actually causes contractions of your stomach to help empty out. So sometimes that can really help with bloat from G tubes. And then the other thing that we see a lot in kiddos with G tubes, and this is Duchenne, you know, irregardless of Duchenne, is something called Sibo, small intestinal bacterial overgrowth. And this has a lot to do with overproduction of gas from bacteria that live inside our gut, right? We're lined with millions and millions of intestinal bacteria, some good and some bad. And it's often the bad ones, what we call the anaerobic bacteria that die in the presence of oxygen. It's those that feed off of what we put into our body and can produce excess gas. So sometimes I'll use, even in these kiddos with bloating, is a short course of a true antibiotic. There's one for kids called Flagyl or metronidazole. It's twice a day. It comes as a liquid. It can go through a G tube, and that can really help target those bad gas-producing bacteria that can increase our bloating. And if that happens, you know, sometimes I'll put kids on an antibiotic, you know, every 3 to 6 months for a couple weeks, which can really help promote, you know, tolerance of feeding. If it doesn't work, you know, then we may be stuck at a J.
Okay. The next question we have is G tube placement, general surgery by gastroenterologist, or intravenous radiology. Our plan is to do the latter. Thoughts?
All right, so this is controversial. This is, I think, if it's the very first tube that needs to be placed, it should either be with a surgeon or with a GI. My surgical colleagues will often state that the reason they like to do them is they can visually see the outside of the stomach. So it is a surgery. It is a little, two usually very small incisions in the skin, one to place a camera so that they can see where they're looking, another small incision to place an instrument to be able to poke a hole, and then oftentimes we'll do a third incision in the belly button to insufflate the abdomen with air or CO2. Now they like doing these tubes because they can visually see exactly where they're going with the poke. They make sure that they're going directly from the skin into the stomach. Same concept, usually a 24-hour stay in the hospital. Sometimes if they're directly seeing these where they're putting, sometimes some of my surgeons in my facility will actually jump right to the Mickey button, so the smaller button from the get-go, as opposed to using the longer tube. As gastroenterologists, we're doing something called minimally invasive, right? So we're doing that camera that goes through the mouth called an endoscope, and we light up the stomach with a bright light. So when we get into the stomach, we find the location we want to see. It transilluminates through the skin, and we can kind of see where the light's coming from. We mark it, and then we quote unquote blindly place a needle from the outside directly into the stomach. The biggest risk is that there could be another organ in there, like your colon. So that video did show a little bit of anatomy where the colon is your large intestine. There's a small chance that the needle done during what we call a peg placement could nick the small intestine or could nick the large intestine. And that is something that, if happens, is a complication of the surgery, will actually need surgery to repair the holes in the intestine. So safest, I would say, is probably with the surgeon, but the risk is a little higher because it is under a little bit more anesthesia, and it's a little bit more complicating from a surgery standpoint. But regardless of which one you ultimately choose, I think they've been done for such a long period of time that you'll be in good hands with regard to whomever you choose.
Just to follow up on that question as well, they wrote in, my son has reduced pulmonary function and is a difficult intubation.
That's a good question. Oftentimes when we place G tubes, our boys, not for Duchenne specifically, but they're not intubated. I don't know if, in all honesty, I haven't done enough or been in enough rooms with the surgeons to know if that's something that they preemptively do because it's general surgery or not. So you would have to ask.
Okay, great. Another question we have is, do they feel hunger when they are using a feeding tube?
Rosalie, I'll let you maybe take that one.
Yes, Christopher definitely feels hunger, and he says he even tastes the formula as it's going into his G tube. The doctors had even told us that if we wanted to liquefy food and put it in, that the kids can still taste, even though it's going into their stomach. But yes, he does definitely get hungry. He gets hangry.
And just to follow up for my question, going off of food, how do you know when is it too much food? You're administering too much food or too little. Does that just kind of depend on the patient, feeling full or not?
Yeah, so I think this is where, whenever a tube goes in place, you want to make sure that you have one of two people for sure involved. And I think the champion here is a dietitian, right? So you need a nutritionist, a food expert to make sure that we're getting enough protein, fat, carbohydrate, and micronutrients, and choosing the right formula. So, tube feeds are, there's dozens of different types of formula depending on age, size, composition, allergies that we alluded to that can go through the tube. And there are what we call regular strength formulas, and then there are higher strength calorie formulas, which become a little thicker. So this is really all dependent, again, individualized meal plan. But I think your dietitians are the ones who usually who quarterback that and make sure that we're getting enough and not too much.
Okay.
Yes, Chris.
I'm sorry, go ahead, Rosalie.
No, Christopher is followed by when we go see the gastro doctor, the dietitian is always there as well. And they calculate his calories, they watch his weight, they watch his BMI, just to make sure that, and it's been adjusted, different formulas, different amounts, just because he's lost weight, he's gained too much weight, until they find like the optimal area, that sweet zone. And he's been pretty steady, but it's definitely the dietitian has a lot to do with it.
And to that point, these formulas are mostly commercially made. There are organic formulas out there. So the Kate Farms that Rosalie mentioned is a really good formula. Some of the big companies, Abbott, AbbVie does make an organic product as well. And then there's this new concept over the last several years about something called a blenderized diet, where you take the food that you're making for your household and you liquefy it, you blenderize it, get it to the right consistency, and then give that feed directly through a tube. That's a little bit outside of the scope of this talk, but the dietitians, the nutritionists, the ones who can calculate what the food material is, can help you identify if would be a candidate. I think if you're getting fed into the stomach as a G tube, a blenderized diet is an option. If you're getting fed into the small intestine, a blenderized diet can be done, but it becomes a little tricky because the tubes tend to get clogged.
Just real quick, Rosalie, did you say you use Kate Farm products?
We do, because Christopher has his two main allergies are soy and wheat, and most of the other formulas are, their base products are, ingredient is soy and wheat. So I wound up doing research and finding Kate Farms.
Okay. This is a question that I think, I don't know what's the best way to answer it, but do all Duchenne boys and men end up on a feeding tube with Duchenne?
Well, I don't think all. I think it's making sure that every 6 months we're doing those screening questions for the swallowing, right? It's something that we don't want to overlook. We don't want to aspirate if your kiddo's showing up sporadically with a pneumonia once a year, and the question is this just bad luck that he's getting what we call community-acquired pneumonia? The biggest question is, could he be aspirating? So I don't think every boy eventually is going to get one, but I think it's all dependent on the disease and how far it progresses.
And Christopher was extremely rare and very young. The doctors were kind of taken back that he was aspirating at his age. So it was an unusual case.
Great. And then just going back to your point, every 6 months, families should be doing the swallow study test.
They should be doing the survey, so that kind of questionnaire, or at least being brought up at those visits are, how are we swallowing? Are we choking? How do you feel when you're swallowing liquids versus solids? Are things getting stuck? Coughing, gagging, choking when eating? I mean, those are, 60 seconds worth of questions and answers that can really say, hey, do we need to think about a swallow study?
Okay. All right, and then we've got one last question, and I think we'll wrap it up here. I know we're a little bit over time. We got a lot of thank yous, though, for both of your insight. People really appreciate it. Last question is, my son is 100 pounds. We would like to see him gain some weight. Can you explain refeeding syndrome?
Oh, good question. So refeeding syndrome is a little bit different. Refeeding syndrome is where, in essence, your body is starved for a set period of time, and you start feeding back, and the body is almost kind of shocked into seeing so much nutrition so quickly. So there's a lot of imbalances that can happen with your electrolytes, specifically your potassium, your phosphorus, and your magnesium. So if there's ever concern about, hey, my kiddo hasn't eaten for a while, has lost a lot of weight, and I'm worried about refeeding syndrome, you need to have this done in the hospital. So the doctors need to bring you into the hospital and slowly give you back food or formula through a G tube, or if we're eating orally at the time, and we have to monitor your electrolytes every 12 hours for about 48 to 72 hours. After the 72-hour mark, if you don't refeed, if you don't develop refeeding syndrome, then you're good to go home. But the electrolyte imbalances can lead to cardiac arrhythmias. So it's something that you want to be very, very cautious with. They discovered this, in essence, after the Holocaust. Once they started saving some of these survivors from the Holocaust, these extremely malnourished patients, and they started refeeding them. And as soon as they saw food, many of them went into cardiac arrhythmias and unfortunately died afterwards. So refeeding syndrome is a real thing you have to be careful about.
Oops, sorry guys, I was muted there for a second. Still haven't figured out this system since going virtual. Thank you both though, very grateful for both of you to be speakers today. This was a fantastic presentation with a ton of information. Thank you all for attending this webinar. If you have any more questions or would like to be connected with Dr. Cordova or Rosalie, please reach out to us at Jeff Foundation. You will receive an email follow-up with contact information and this recording. Please feel free to share Jeff Foundation's webinar series with your friends and families in the Duchenne community or someone you may know who might benefit from this. We look forward to you again on a virtual webinar series soon. And one more time, just thank you to both of you for speaking with us today. We really, really appreciate it. So that's all. I know we ran over time here, but we'll let everyone go. Have a great day, everyone.
Thank you, guys.
Thank you.